Hi everybody, it's Jennifer. I just wanted to touch base with you quickly today because I know you're busy. I just wanted to go over some of the new information that came out recently in the antibiotic guidelines for respiratory tract disease patients. These were put out by the working group for the International Companion Animal Infectious Disease group and were published, I think, just last month in the Internal Medicine Journal. I'm going to put a link to those down in the comment section though, so if you haven't had a chance to read them, they'll be down there. For those of you who don't know me, I'm Jennifer Garcia. I'm an internal medicine specialist and the co-founder of Vet Companion. The guidelines, so they cover mostly feline bacterial upper respiratory tract disease and then also canine respiratory disease complex, otherwise known as kennel cough or infectious tracheobronchitis. They also touch on bacterial causes of bronchitis, pyothorax, and pneumonia. So we'll just touch on a couple of the things that I found interesting on there. Vet Companion users, never fear, all of this information has already been updated in your monographs. If it pertains to bacterial respiratory disease, it's already in there. So a couple of things that I found interesting, one had to do with nasal cytology. So I see a lot of patients that come in for upper airway disease or lower airway disease workup, and they've already been treated at their family veterinarian with antibiotic therapy based on nasal cytology. And unfortunately, as you know, there's so many bugs already in the nose that it's such a mixed population that you're really not going to get anything useful out of that in terms of guiding your antibiotic choice. And the working group actually said that that's no longer something that they recommend doing. Nasal cytology, because it's not helpful, they actually don't do it, and they don't recommend culturing nasal discharge either for the same reason, just it's too difficult to interpret the test results. And so don't do that anymore. That's a good thing. That's one less thing to do. The other thing that they talk about is that I thought was interesting is just an observation period. So if the patient is just coming in with sniffling and sneezing and that kind of thing, they actually said that just take a wait and see approach. If they're otherwise eating, drinking, and acting okay, they have a recommendation to institute just a 10-day observation period where you don't institute any antibiotic therapy at all, which makes sense. We know a lot of these patients have viral origin disease, and so putting them on antibiotics a lot of times isn't necessary if they're otherwise doing okay. If in that 10-day window, however, things change, they develop a fever, there are other clinical signs that are concerning, then they do recommend instituting empiric therapy, antibiotic-wise. And the one that they recommend doing is doxycycline. That tends to be the one that's the most well-tolerated and also covers the most potential pathogens that we're dealing with these patients. So Bordetella, Mycoplasma, doxycycline is a good choice for those. And time-wise, they recommend 7 to 10 days of doxycycline therapy. Most cases are going to get better in that time frame. So for those patients that don't get better in that time frame or do have clinical signs that are concerning of more lower airway involvement, then they recommend doing more aggressive type testing as well. So a lot of times, the question is, when do we do the lower airway sampling and that kind of thing? And so the 3 cases that they would recommend doing that are if you have a patient that has developed worsening of their clinical signs during that observation period. If they're getting worse even with just doxycycline therapy, things are changing and they are not doing well. Or anytime you have a patient who is from a breeding facility, shelter, kennel situation where you're concerned about a potential respiratory disease outbreak, then those are absolutely ones where you're going to have to do more testing. So lower airway sampling and submitting that for culture and sensitivity testing is definitely indicated. And then the molecular assays, things like the PCRs, where you do screening for a large variety of upper airway and lower airway pathogens. The good thing about that testing is that it's very sensitive. The bad thing is that it's very sensitive. And so a lot of times it can make interpretation difficult because there are things that you can sometimes see in healthy populations as well. So that's why they say reserve that testing for patients where it's clearly indicated so that you can have more faith that those results are going to mean something to you and that you're going to be able to institute something based on that information. Let's see, the other things that they talk about have to do with pyothorax. So, obviously those are going to be cases where you're going to want to do culture and sensitivity testing, but Antibiotic-wise, one of the things that they actually recommend against, and that has always been sort of an area of controversy, is instilling antibiotics into the pleural space. So, they say that you have to put tubes in these patients in order to drain the chest space because that's going to be key to their therapy. But there's always been some concerns about, do we put antibiotics in there? And they actually say that absolutely do not put antibiotics into the pleural space. There's no evidence to suggest that that's helpful, that it minimizes or that it helps keep them out of the, get them out of the hospital faster. None of that. So yes to intermittent or continuous drainage via chest tubes, no to instituting any sort of antibiotics into that space. Lavage. Yes, you can do a lavage. There's with or without lavage. They're not really clear on whether or not that's indicated. I think it depends on your case and what's going on with it. In terms of pneumonia, one of the things that I thought was interesting was if the owner can afford it, the client is able to do it, they actually recommend putting these guys in the hospital regardless of their disease severity. So if they have pneumonia, even if it's not bad, they recommend the hospitalization because parenteral antibiotics are going to be your best bet with those cases in terms of getting them better faster. So parenteral antibiotic therapy, regardless of disease severity, is one of their recommendations. And again, it depends on whether or not your client can do it. We all know we have to do these things based on what our clients can do and what our patients can tolerate. So, these are why they're guidelines, and we have to make the best judgment that we can for our patients. So those were the biggest things that I came away with from the guidelines. If you have any comments, please feel free to let me know if you have any questions. I actually made also a little table for you that I'm going to put in the, I'll put a link to it down below as well. It has all the antibiotics that they recommended for any of those diseases that we talked about, and the doses will be included in there too. So it was great talking to you. I hope you have a good day. Coming up, we're going to be doing some more videos and handouts, hopefully for evidence-based veterinary medicine and how we can help you learn more about that and institute it in your practice. But that's it. Hope you guys have a good day. We'll talk to you soon. Bye.